Okay, it's now 4 minutes past the hour, so we'll start. Welcome everybody to the February meetup of FEMS project. Today we have a topic of our hackathon, so Pediatric Sepsis Prediction Hackathon, which was conducted during January and February. So we will go through this topic in detail. As you know, so we have a series of winter meetups by the FEMS project, where we are today on the second one. There has been one this season on the practical use of anonymous and synthetic data in healthcare, and we will have one more in March, which is about differences and similarities between the European health data space and pediatric health data space that we are aiming to build. All the presentations also from our autumn series are available on the YouTube channel of the FEMS project, so you can always return to those. Or if you have missed the meetup, so feel free to check it in the YouTube channel. My name is Pekka Kahri. I am the coordinator of FEMS project. Our today's agenda is here displayed, so I will very briefly introduce what FEMS project is about. Then we have a keynote from Dani Priet-Alhabra, and then we are going into the actual challenge. Aida Felipe from San Juan de Deu will describe the challenge. Why are we setting up this? What is the purpose? And then Bruno Roballo from Erasmus will describe how the hackathon was conducted. And then Lydia Briggs from Gauche will finally announce the winner and introduce who were the top performing teams in this hackathon. But very briefly, why did we start FEMS project? The need in pediatrics for data sharing is more urgent and more prominent maybe than in any other field discipline, especially due to the fact that there is small numbers of patients in pediatric patient groups where in fact cross-border data sharing becomes increasingly important. So in order to get statistical power, in order to get assessment of real-world effectiveness of new expensive therapies, in order to engage more with the medtech innovators, pharma, especially on the field of machine learning and artificial intelligence, which is hungry for data. And then especially in the tertiary pediatric care, many regions and countries may have only one pediatric hospital, so quality improvement through benchmarking may not be possible in a national setup, so we need international collaboration on data sharing. FEMS is a project financed by the European Commission Horizon Europe Programme and UKRI with 14 partners, 7 million euro funding, and we are exactly halfway, starting in October 23 and will conclude end of September in 26. Consisting of 6 hospitals, pediatric hospitals or pediatric departments in general hospitals, and then technical and business partners and ECO Association as a not-for-profit organization bringing together a lot wider network of pediatric hospitals. In the core of our activities is to build a technical platform and make it feasibility proof of concepts through clinical use cases, which we have 3. The first one is on cardiology operations benchmarking, especially on congenital heart disease. And there is a full presentation on the benchmarking in our December meetup, available on YouTube. Then there is the sepsis prediction for pediatric intensive care units, which is our topic today. And then third use case on hematology, hemophilia, how to develop and validate a machine learning-based prediction algorithm to help the treatment of hemophilia patients. And as said, so today we are focusing on our use case 2, which is on the sepsis prediction for pediatric intensive care. And now next, I would like to give the floor to Professor Dani Priet-Alhabra, who is the head of health data sciences at Botnar Research Center and professor at the Oxford University and Erasmus Medical Center, for a keynote speak about data and its uses. Daniel, the floor is yours. You can take control of the slides and about 15 minutes, you are on the spotlight.
Thank you so much. Delighted to be here today, and thank you for your hard work. It's really important, even for those of us who do not really have a focus on pediatrics. I think it's been said already, but it's an area where we need more and more data, and it's really hard to gather that data. Okay, I think hopefully in the hope that we will inspire you a little bit with some work we have done, I'm going to be talking about something we called study-a-thons in the duration of the Eden project. Eden was an IHI project where I think many of you, or a few of you at least, participated as data partners. The idea in that project was to harmonize data to a common data model. We used OMOP, as you will see, and then we did a few of these study-a-thons where we would gather people for a whole week and conduct a study, as you will see. I will start by talking very briefly about the principles of open science and OMOP analytics and how that catalyzed the generation of real-world evidence. And then I will tell you a couple examples of Eden study-a-thons that we conducted.
Are you seeing the slides changing? Asking the audience. So I am,
but I'm not sure.
How about others? Bruno, can you confirm?
No.
No. Okay.
Okay. Maybe I will share move the slides from here. So let me just know when to.
Okay. Go a couple more ahead, please. This is where I was. Perfect. Thank you. Yeah. I will ask you to help me with this then, Kari, if that's okay. Yeah, so this slide is basically to explain the situation of the whole area, of the whole space of observational real-world evidence studies. What you see in there is an extract of more than 200,000 observational papers published in PubMed. We use some machine learning to extract the estimates reported in there. And you can see this very interesting kind of funnel shape. If you know your stats, you will figure out very quickly that the threshold that's kind of shown in there or intuitively read in between lines in there is the p-value 0.05. And this is, I think, the strongest and saddest evidence I've seen in my life of p-hacking. But this is the field. Like, people tend to publish papers that are interesting or significant, if you like. If we go to the next, please. So basically, in the whole OMOP ODC community, we try really hard to prevent that by applying full open science principles. And this has then transformed the whole field of real-world evidence, particularly in the regulatory area. And the things that we claim we need to be done includes declaring a protocol before you conduct analysis, sharing all your analytical code, and sharing all your results, regardless of whether they are significant or interesting or not. And I think this is the only way we will be fully transparent and reproducible and trustworthy. We go to the next slide, please. And this is an example of one such study. This is a study called Legend, published in The Lancet in 2020, where we compared all antihypertensives to each other, and we looked at a very large plethora of outcomes, including safety and effectiveness. Almost 8 million hazard ratios, as you can see on the plot. And interestingly enough, I guess, not distributed around the p-value 0.05, because of course that is not the reality of the world, right? So this is what we aim for. I'm pretty sure that the ones below the dashed lines, which are the ones that are significant, will be the most interesting ones potentially, but we do need to report everything that we have done so that we can take into account the rates of type 1 and type 2 error. Next slide, please. So how do we do this? We basically divide the large and convoluted journey that goes from source data to reliable evidence in two pieces. The first piece is where you convert your data to a common data model. As I said, we used OMOP, and we continue to use OMOP in many initiatives. And then the second part is what becomes much easier, because once you have all your data in the same common data model, we can and have already developed a lot of tools to do the second part of the analysis, which is your federated learning or federated analytics. Next slide, please. The OMOP CDM, just very, very briefly, it's a patient-centric, tabular, extendable, relational data model, and it was specifically built for analytics. I'm not going to spend time going through it. You can find this in your own time, but you won't be surprised that it will contain the usual tables and measurements and conditions and drugs and everything that you do have in the data that you guys are probably using in your daily routine. Next slide, please. This is the idea, basically. We have different data partners to the left who have their source data in the local format, vocabularies, what have you. They do ETL that data. They each have an OMOP CDM instance of their data. And then somebody, maybe one of these same data partners, to the right-hand side will be generating code that runs against that data and generates runs against the data and generates results. And it's only the results that are shared with the leading team for a specific study without sharing any patient-level data, and therefore protecting patient privacy and data privacy by design. Next slide, please. This is what we did, for example, in Eden. So, and this is what we're going to do in upcoming projects. You have a study team or study leads, as I said, with a rotational principle. So people will be taking that role depending on their interests and expertise. They write code, and to the left-hand side, you have different data partners who have their local database and the OMOP instance of their data. We have some sort of execution engine in between to facilitate the execution of the analytics, and then we get the results back in an aggregated manner and then pool them. There's, as I said, a ton of different tools that can be used to do many things. If we go to the next slide, please. The idea being that if you start from data that has potentially similar information, but looks very different, like in this example, any analysis is quite complex, because even looking at something relatively simple, straightforward, like the adherence to a medicine, means that you will need to write a script for each of the data partners contributing to that study. And that's clearly not scalable, not transparent, very hard to reproduce, and very slow and expensive. Next slide. The beauty of having a common data model, and in this case using OMOP, is that once you've mapped all that data to the same format and the same common data model, we then invest as much effort as needed to have very solid software that will then be reused continuously and improved over time to do whatever you think is important for you. So, for example, if you wanted to do prediction, there is a patient-level prediction. If you wanted to do something specific about sepsis, you would have someone who has created a phenotype for sepsis, and then you would validate that instead of starting from scratch. So the idea is that once you have the same common data model everywhere, you invest in having software and writing very little code, just basically parameterizing the software that already exists. Next slide, please. Now, let me tell you a couple of examples of when we did this in practice. The first one, this is now going back more than 6 years in time. December 2018, we had just started the Eden project. A few partners around Europe had already mapped their data to OMOP, and we wanted to do this crazy idea that we called a study-a-thon. And this is something I organized in my college, Lady Margaret Hall, Oxford. And the idea was that we would, excuse me, engage a few data partners from Europe and the US in this case to compare, and this is, I think, less important for you, but still I'll tell you the clinical example. We were comparing two types of knee surgery: total knee replacement, where you replace the whole knee, versus partial knee replacement, where you only replace the part of the knee that has really bad arthritis. Yeah. If you go to the next slide, please. This was a proof of concept where we said, how much can we deliver in a week? Multidisciplinary effort with clinicians, epidemiologists, data scientists, engineers, you name it. And we had a whole plan for the week, which was a little bit more messy than what it looks like in this slide. But the idea was that we would achieve as much as possible to look at the comparative risk of these two different types of knee surgery, both very safe, but yeah, there's some controversy on which one is preferable. We go to the next slide, please. The motivation for this was that there had been just before a systematic review of the literature on this topic, where colleagues had compiled 20 years of data in one paper published in the BMJ, as you can see there. And we wanted to see whether we could predict that before it went out. And you can see to the left our findings, data from the US and the UK in this case, where we found that people who received this less well-known surgery known as partial knee replacement, had a lower risk of venous thromboembolism or blood clots after having surgery compared to those who received the total knee replacement. That matched perfectly with the previous data that have been produced over 20 years, as you can see to the right-hand side of the slides. If we go to the next slide, please. If we then look at implant survival, this would be how long does the implant stay inside you, and or what is the risk that you will need to go and have another operation to replace it or remove it. There are tons of data, as you can see to the right-hand side, over 20 years of data that have accumulated suggesting an increased risk of revision surgery or a reduced survival of the implant in people who receive the partial knee replacement. And that is exactly what we found as well in our proof of concept study-a-thon. Next slide. Now, the second study-a-thon we conducted, this was motivated by something we have kind of forgotten by now, which was the pandemic of COVID-19. In March 2020, we all had to change the way we were doing things in life, and we started this study-a-thon using the Teams environment that we are also used to nowadays. This was a global initiative with more than 300 colleagues from all over the world, as you will see in a second, working pretty much 24/7 because we had different time zones covered by different people for 4 days. And it wasn't really like a final thing. That this effort continued, as you can imagine, during the whole pandemic. But I will just show you the first results that we produced. Next slide, please. The first result is that we managed to put together a massive network of colleagues who had access to data on patients with COVID from the US, Europe, and Asia, as you can see, including more than 4 million people tested for COVID and over 1 million cases. And almost 250,000 hospitalized with COVID-19. We go to the next slide. And we did something quite simple, but of course at that time very interesting, which was looking at the treatments that these people were receiving when they got hospitalized with COVID-19. This paper is published in the BMJ 2021. And as you can see here, this is, I think, an example that I hope we will never see again of very gross treatment heterogeneity, of course, because we didn't really quite know how to treat these patients, right? So you can see how hydroxychloroquine use went from 2% to 85%, depending on where you looked at. If we go to the next slide. And this is basically time trends. And I think this is beautiful as an observation to see how hydroxychloroquine became very commonly used in March and April, but then after some safety concerns from some studies, including one of ours published in April, there were some warnings from the regulators, both FDA and EMA, and the use declined very rapidly. The FDA also revoked the emergency authorization they had given for the use of hydroxychloroquine in COVID. And since then, you pretty much don't see any use. And then finally, dexamethasone corticosteroid, of course, following the opposite trend. So, the minute we learned that this drug reduced mortality from the recovery trial, the use jumped very, very quickly and then remained higher over time. I think that's my last slide. Hopefully I've still left some couple minutes in case there's any questions, and I hope that was interesting and a good motivation for your hackathon. Good luck with that.
Thank you very much, Daniel. A very exciting and insightful introduction to what can be achieved with federated data analytics and when data is harmonized into a common data model, and there is a methodology in how to tap that network of data resources. This is brilliant. Thank you very much. And this is where we also in our FEMS project are relying upon. So going to a common data model and OMOP, as it is becoming or has become the standard for observational studies. So this is a really strong foothold also, where we will be building the efforts of FEMS project. So I don't see any chat questions here. So thank you.